It's my pleasure to be here, to be part of the faculty for the PG course. So my topic is to see with you the role of imaging in diagnosing cirrhosis. This is the outline that has been given to me, and I will highlight the imaging features of cirrhosis. Correlation between imaging and disease severity will be detailed in the syllabus, and I will end up with some examples showing pitfalls in the non-invasive diagnosis of cirrhosis. With imaging, we may have different approaches, starting from the morphological findings, then going to the hemodynamic findings, completed by the elastographic findings, and indeed we will see the role of the combination of the different imaging criteria. So let's start with the very classical finding, the morphological one. The first one is distorted liver architecture. Indeed, this is well known by you hepatologists and pathologists as well. If we look at the microscopic specimen showing the small benign regenerative nodule that are surrounded by fibrous bands. This pattern can be seen also on imaging. Let's start with the ultrasound showing the small regenerative nodules that appear hypoechoic, surrounded by fibrous band. But it may also be depicted on CT imaging, either non-contrast or contrast-enhanced. But by far, the best imaging modality to show the distorted liver architecture is MR imaging, with the two best sequences. The first one, which is a fat suppressed T2. Here, the regenerative nodules appear hypointense and surrounded by the hyperintense bands, completed with the dynamic delayed contrast enhanced. As you can see here, example in the same patient, the changes in liver architecture are much better delineated under 5 minutes after contrast medium administration compared to the portal venous phase or the 3 minutes. The second morphologic findings is the nodular liver surface, well known by surgeons and pathologists indeed. And again, imaging can depict these changes. Let's start with the ultrasound, when we can see this irregular liver surface. But as you can see, these two images were obtained in the same patients, that the nodular liver surface is much better depicted on using high-prod ultrasound, and this is a key that we should use in evaluating patients with a chronic liver disease. Indeed, we can also use MR or CT to show the liver nodularity. And fortunately, there are some automated liver surface software that have been developed that are able to depict not only cirrhosis but also extensive fibrosis with a high level of sensitivity and specificity, as you can see. The third very important morphologic findings are related to atrophy-hypertrophy complex of the liver. Indeed, you know that some liver segments may shrink, whereas others may enlarge. We don't know exactly the reason why, but classically there is a shrinkage of the right liver as well as the segment 4, and the segment 4 is of interest because it is probably the earliest sign that affect the liver, whereas there is an enlargement of the left liver lobe and the caudate lobe. These changes can be seen on ultrasound and have been described more than 2 decades ago by Michel Lafortune. A threshold of the transverse diameter of the segment 4 is 3 centimeters in order to differentiate cirrhotics versus non-cirrhotics. Again, CT or MR can evaluate morphologic changes of the liver, but is not as accurate as ultrasound for assessing the size of the segment 4, as it is obtained on an oblique scan on ultrasound, which is not done or cannot be done with the CT anymore. There are some other morphologic findings that can help you and have been described, such as here the posterior hepatic notch or the enlargement of the hilar periportal space. There are some other very interesting findings, such as the peribiliary cyst. Actually, peribiliary cysts are seen in two very different clinical situations. First, the chronic liver disease, as we are currently discussing, but also patients with a polycystic liver disease. What is the explanation of seeing peribiliary cyst? You know that there are peribiliary glands that usually communicate with the bile ducts, and when the liver compresses these glands, the communication is not working anymore, and then we can see enlargement of this peribiliary cyst. Splenomegaly is a classical finding, and many cutoffs value have been proposed. The one that seems the most accurate is when the longer diameter exceeds 11 centimeters. Indeed, there are some other morphological findings such as ascites, gallbladder wall thickening, but they are less sensitive and specific than the previous ones. Now we move on to the hemodynamic findings, which are best explored by Doppler ultrasound, and several signs have been described. Briefly, it is interesting to split them into, first, the signs of portal hypertension, and then some signs that are more specific for cirrhosis. What are the best signs for portal hypertension? Indeed, the presence of portocaval collaterals. They are the best, by far, for detecting portal hypertension with a sensitivity exceeding 80% and a specificity of nearly 100%. Yet, they are not specific for cirrhosis. And let's see here the four main important or common territories for portal hypertension. This is the gastroesophageal. Here the drawing represents the portal venous system in white and the caval system, and we can see here the collaterals that are very well seen on ultrasound. The second one is the paraumbilical, with again the portal vein and the left branch of the portal vein draining to the paraumbilical vein, extremely well seen on ultrasound, but here on contrast-enhanced CT. The splenorenal shunts that can be either direct or indirect, and we see here large collaterals around the spleen. And last, the perirectal, with the reversed flow within the inferior mesenteric vein draining to the IVC. Other findings have been described a long time ago, dealing with hemodynamic changes with increased portal diameter, decreased portal velocity, and later on decreased portal venous flow. However, they are not as sensitive and as specific as the portocaval collaterals. But there are also hemodynamic findings that are really more related to cirrhosis. And a very important one is the change in the hepatic venous flow. As you know, on the left, hepatic veins have got a triphasic spectrum, which is related to the cardiac cycle. And with the severe worsening of the chronic liver disease, we see a flattening of this waveform that's with two different stages. And this is extremely specific of presence of cirrhosis. Other hemodynamic findings have been associated with the cirrhosis, such as increase in the hepatic arterial resistance index and increase in the hepatic arterial blood flow, but again, they are not as sensitive and as specific as the changes in the hepatic venous pattern. Last but not least, elastographic findings. Dr. Castera has highlighted the importance of liver stiffness in diagnosing cirrhosis, but also advanced chronic liver disease. Briefly, there are two technical approaches, the static one versus the dynamic. The static one is no longer used in the liver because it was not sufficiently reliable. With the dynamic shear wave imaging, actually the reference method is the FibroScan, as it has been very well said before. And here I will point out that we can use also indeed ultrasound-based elastography and MR elastography. Just an example to see how it looks like. On the left, this is a color map using ultrasound-based elastography with a change in the color map with the increasing liver stiffness here. So the velocity of the propagation wave has been converted in kilopascal. Here we have seen an example of an MR elastography showing high speed sequences that are able to capture the propagation wave and leading also to a color-coded map. But indeed, these techniques are very different in terms of availability and cost. Anyhow, MR elastography is the only one that is nowadays a 3D technique. How do these techniques compare with the transient elastography? Indeed, there have been several studies. I'd like just to highlight the one published by Christophe Cassinotto in 2014, comparing FibroScan with the shear wave elastography with the SSI and RFI. And as you can see, with the SSI, they obtained the highest area under ROC curve, not only for the diagnosis of cirrhosis versus non-cirrhosis, but also for the diagnosis of significant fibrosis. What are the performance of MR elastography? Actually, MR elastography equals ultrasound elastometry, but with a better reproducibility. But things that it is very important and that has been stressed already by Dr. Castera is the MR values are much lower, so it is difficult to compare from one technique to another one. Indeed, because we have several approaches, it is important to combine criteria. And I would like to stress these two different approaches. There have been several others, but I have picked up what I think are the most important. With ultrasound, we can, as you have seen, combine morphological criteria, hemodynamic criteria, and also elastographic criteria. In this study, first of all, they took into account presence of at least two of these findings: nodular liver surface, because it's highly specific, increased spleen length, and demodulation of the hepatic vein. So in that population, at least 2 out of these imaging findings had a sensitivity which is not very good, but a high specificity for the diagnosis of fibrosis. And then, if we pick up only 1 out of these criteria, plus an increased liver stiffness more than 9.5 kilopascal, the sensitivity increase with a slight decrease of the specificity. This highlights the role of combined imaging criteria. What about MR and how MR elastography compares with the MR imaging? In this another study, they have selected important imaging findings at MR: liver texture, nodular liver surface, volumetric changes, and portal hypertension. And MR elastography outperforms MRI for the diagnosis of significant fibrosis with a very high sensitivity and specificity, and cirrhosis also with a high sensitivity and specificity. Indeed, there are other approaches which are mostly quantitative and interesting, but they are not largely validated, and they are still, for some of them, research. Texture analysis that can use CT on MR can differentiate cirrhosis versus non-cirrhosis. The perfusion studies showing decrease in the portal venous inflow in cirrhotics compared to the non-cirrhotics is also a very important approach. Advanced diffusion MR imaging that enable to separate the perfusion-related